role of vaccines for a very vulnerable segment, infants and pregnant women, with a focus on RH incompatibility. To deliberate on this, we have a very distinguished panel who are leaders for women's healthcare in this great country and beyond, and who are very accomplished and my very beloved friends. So it's my pleasure to invite Dr. Hrishikesh Pai, the president of our parent organization, FOGSI, with over 40,000 specialist members on board, the world's largest, and Dr. Jaydeep, who will be next stepping into this prestigious post. He is the president-elect for the current year. Dr. Bhaskar Paul, a senior consultant gynecologist and obstetrician, who is also the link between India and the Royal College in London, who is a consultant at the Apollo Clinialis Hospital at Calcutta. The young talent who is blooming, Dr. Basab Mukherjee, who has held the post of Vice President of FOGSI and is a gynecologist at the Ashirvad Clinic at Calcutta. Last but not the least is another champion and asset to the nation, if I may say, Dr. Chinmayi Ratha, who is a member representative and secretary of the RCOG South Zone of AICC, that is All India Coordination Committee of the Royal College. She's a fetal medicine specialist based out of Hyderabad. So in this entire scenario of the 1,000 days, which is quite a buzz, whether it is for nutrition, whether it is for mental health, whether it's for immunization, whether it was any damn thing, the crucial start of the 1,000 days, which is a continuum from the first 280 days of pregnancy, then to the first 2 years of the newborn and the infant. So that's the segment that this panel hopes to address on a variety of issues. My first question naturally goes to the leader of the ship, Dr. Hrishikesh Pai, who is the president and the medical director at the Bloom IVF. Hrishikesh wants to bring in a change. Who doesn't want to change? Change is a constant. We all know those buzzwords, but love is a change. Dr. Hrishikesh Pai, you have 3 important pillars in this Badlao, and I want you to reflect on, with respect to immunization, how your pillar on Samanata or equity, no matter what is their economic, social, educational background, everybody deserves to have the preventive care by vaccination. How does that fit in? Integration. Anybody comes for anything, no matter any age, wellness is a mantra, and how you will integrate this into your programs. And lastly, the power of technology, which has brought us together on the IHW platform today and many more platforms with ease and seamlessly. So bringing out Badlao by Ekikaran, Samanata, and Techniki, or Takniki, as how Dr. Pai calls it, with respect to immunization. How does your thought process revolve to get this action rolling? Dr. Hrishikesh.
Thank you, Hema, for inviting me here, and all my friends and colleagues are there, and would like to appreciate the IHW Council and the support that VSP has given for this program. So, one of my presidential initiatives has been the adult vaccination program. Maybe, it's not that easy to implement, but I always was looking at our colleagues, that is the pediatricians who have effectively implemented that program in their practice. So I think that we need to also do it, and that's why I have defined that concept with a word called Raksha. So Raksha is the presidential initiative for adult vaccination, under which we have got different silos. Each silo has got, because different companies have got different concepts of how they want to promote the vaccine. Just now in the morning only, one of the companies had contacted me that they would like to do awareness program, this thing in the public space through radio. So different companies have different strategies. So if you look at it, we need to break up any strategy into 4 components. One is the research component. We need to look at what is available, and at one point in time, we would definitely look at the second component is to do guideline. You need to have a adult vaccination program guideline. The guidelines are already being done by the Federation. Already 9 guidelines have been released, and the guideline will come out with the full vaccination guideline. The third part of it is awareness and advocacy. Advocacy at the level of government. Just now I'm in the ASOCAM program. I've just muted that program. It's on thalassemia. So when they come, when they start the thalassemia panel, where I'm a part of the member, one thing I'm going to tell them is this is the problem in India. Everyone has got different vectors. Everyone has different directions. So yes, vectors are important. Individualization is important, but integration is upload. That's what I define my Badlao. So we have to integrate it. Now we can have, so we need to see how we can bring all of them under the National Digital Health Mission. Just now the talk was going on by the Director of National Digital Health Mission. So all the data has to be brought in. The thalassemia data has to be brought in. The vaccination data has to be brought in into a single digital platform, which will give us the information of how many people are vaccinated and how many are not vaccinated. So please excuse me if I start talking about thalassemia, vaccination program, because that's what it is all about. You need to integrate everything. So you need to, bring it into the digital mission for data recording. You need to have a common implementation policy. So coming back to my conversation, advocacy and awareness building is important. And the fourth part is obviously implementation. And implementation is in the form of my scheme of Raksha Adult Vaccination Center. So I've already talked in the morning. I said, we must have a training program for all our, we need to make them aware that this is a socially proactive program, adult vaccination, as well as a income generating program. The income generation is also very important for long-term sustenance. You cannot thrive on give outs.
Right.
You have to generate on your own sustainable program.
Model.
It has to be financially sustainable. You can't say keep on taking freebies from everywhere. So it has to be income generating. We must talk the conversation. We should not shy away for talking the conversation of income generation.
Yes, Hrishikesh.
So
I think
when the patient walks in,
I think there is some interruption, Hrishikesh. It was fine to start with, but now we have meddled with something.
Then we have for preconception. That is the time we must also screen them. Yeah, I have HPV vaccination, the rubella testing and rubella vaccination. Then in pregnancy, all the vaccines, including the influenza vaccine, the DPT, and the COVID, if necessary, if there is an outbreak, the respiratory syncytial virus vaccination. We must train our people how to take care of side effects. Because there's a fear, you give the vaccine, something goes wrong in your clinic. So all that has to be trained. How do you maintain the cold chain? And we must get our colleagues from the pediatricians to train us in that. So this is the holistic approach we should have for implementing the vaccination program. And that should be done in all our 38,000 members. That is what I believe in the concept of Ram Rajya. Means what everyone, all the members have enough busy.
Thank you so much, Hrishikesh, because I can see that you're really breaking the silos because you're on the SHM thalassemia meeting, you're on the IHW the vaccination meeting, the very organizations, SHM, IHW, collaborating with FOGSI, which is, the largest of the specialist organization, as I said. That means we are opening up our minds into how these collaborations will lead the way. And the point about integration, well taken. You have one opportunity which you will use for multiplier effect of the best that can be done for prevention. I really, really appreciate your time for participating in this panel. And if you need to step out for the other meetings, you can do so. But if I see you appearing again on the screen, then I will again pose a question to you. That's why I have not planned for 2 rounds, because I would address you all, in a wholesome way at 1 round, so that you can be free to move ahead with
Thank
the
you.
other assignments.
Thank you. I would like to add one thing before I
Please.
leave. The person who is most important in this meeting is not me, but the next person, that is Dr. Jaydeep Tang. Because that is the problem with our country. Our country has no continuity. It's absolutely whatever effort that is put in, that is gone into the drain. And that is what we have to. So we have to rise above. So I believe in, what is the leadership should be a structure where a leader keeps innovates. He has to innovate, but he also sustain it. Unless you do that, unless sustenance is done, unless continuity is maintained, and I'm sure I've got a lot of hope from Jaydeep, and he will, because the change has to come from within. If I create something and he sustains it, then the next one after him will maintain it. So that is what it is all about. It is all about sustenance, maintenance, and long-term vision for our country and integration of our country.
I think Hrishikesh, you have already proved yourself with the support that you have lent for some of the major initiatives at FOGSI, like for example, Manyata, which has been running for a whole decade, because you saw to it that you walk the talk, not allowing the program to fragment or disintegrate somewhere along the way, but held a common thread all through the last many, many years. And that reflection, I'm sure, will be taken forward by the leaders today and the potential leaders for tomorrow. Thank you so very much.
Thank you. Thank you. And before I leave, I would say Basab is also one kind of representation of that continuity. He has been very consistent in the field of family planning, and that is what we need from our youngsters. That is what we need to be demonstrated. There has to be long-term sustenance. Thank you.
Thank you. So the succession plan on this
forum
is also very well laid out.
Hema, before I leave, I must tell you that the ultimate sustainer is yourself. You have been there. You've been the president for so many years back, but that's what it is all about. Look at your, commitment to maternal health and to gynecology, that you have sustained yourself. You didn't walk away from the organization. So it's very important for past leaders to sustain the, of course, not interfere with this administration of organizations, but sustain them in a very constructive way. And you are a fantastic symbol of that sustenance. Thank you.
Thank you, Hrishikesh. This brings me to one of the saying that Dr. Jaydeep Tank had quoted years ago in the FIGO leadership meeting, when we had, it doesn't matter, if it doesn't matter to you who takes the credit, then a lot more can be done. So this was one saying, which has stayed in my mind for a very, very long time. And we truly believe that leadership is not in position, but in action. And the action continues with this passionate group, which is driving the purpose of the healthcare for girls, women, and thereby the country at large. Thank you so very much.
Thank you.
So that swings me back to the president-elect in the continuum of the series of conversation, Dr. Jaydeep Tang. A lot has been talked about impact and implementation. The vaccines, as far as the OBGYNs are concerned, again, we are compartmentalized to giving the said number of doses in pregnancy, and there it holds. So in collaborating with the other organizations like the pediatricians or world organizations on various specialities, it is a good thing, but it is also a challenge, because each one is running their own track at different speeds. And then, oftentimes you feel on your own, you could have gone much better rather than collaborating. That is one point I want you to address on your experience. And guidelines, all lying neatly in the shelves and the websites now, but implementing those guidelines, how is, to your mind, how much of it has been impactful? We talk so much about the newer vaccines for the adults and women. Is it just in talking, or have the jabs been given to a significant number? Lastly, the advocacy. Dr. Pai said radio, this, that. Yes, there are many, many, many modalities, different pathways, different innovations. Where have we reached? In short, in a nutshell, what are the action points that arise in your mind as a professional organization leader for the greatest number of years that I have known? How do you translate some of our thoughts into action?
Thank you very much, Dr. Divakar. I will just begin by echoing what Hrishikesh said about you. Your consistency, your enthusiasm, and your passion for maternal health is quite frankly unbelievable. One would think that you would be now, not as enthusiastic as you were, but the way I see you, you are even more enthusiastic than before. And I think FOGSI owes a debt of gratitude to you for so many things, but primarily for the dynamism you bring to the Manyata project and the sustainability that you bring to it along with Hrishikesh. I must thank the council for putting this program together and also having alongside me Bhaskar, my dear friend, Basab, Chinmay. Not to say Bhaskar is not a dear friend, but I have all their own dear friends. But Bhaskar, Basab, and Chinmay, and of course for a panel moderated by you. I think I'll answer your last question first, and that is to do with the impact of the guidelines. And for me, I have always seen guidelines as a starting point. Unfortunately, guidelines they tend to be perceived as an end point, and there is no continuum of care which flows from the guideline to implementation. And I sincerely believe that when there is a guideline, it should also have a plan of action. I believe any guideline is incomplete without a plan of action, is incomplete without certain milestones set to it for implementation, particularly when the issue is as important as the issue of vaccination. Because at the end of the day, vaccination is not only about preventing acute disease, it's about the future. For example, it's not always understood that the vaccines that are currently recommended in pregnancy give passive immunity to the fetus, because there are like pertussis and influenza vaccines. Influenza vaccine, for example, the child is not supposed to receive an influenza vaccine, I believe, in the first 6 months of life. And what protects the child in the first 6 months of life, in fact, is the passive immunity, which is conferred via the mother and the placenta into that child. So for implementation of guidelines, I believe that when it comes to guidelines like these, vaccinations for public health, which have both short and long-term health implications, the guidelines actually incomplete without an implementation plan and setting milestones as to seeing whether what we want in the guidelines has been achieved or not. So as far as the vaccination guidelines goes, I have always been very proud of the fact that India has long been a champion of vaccination. Right. I think we have one of the most robust vaccination programs in the entire world. And the COVID vaccination program is, if any needed any more evidence, then I think that provided ample evidence of our ability to vaccinate what is now the world's largest population in any given country. So I'll say that about guidelines. And honestly speaking, as I said, guidelines are a roadmap, if you will. The problem really is the lack of an implementation plan within the guideline. But for vaccination, I believe that the guidelines have been extraordinarily successful. And what I look to know whether this has been extraordinarily successful or not are not so much the figures, but the sales figures of the vaccines. So if you look at the ORG mark data on the sales figures for the so-called newer vaccines, although they have been around for a long time, like DTaP, or you look at the sales figures for influenza vaccine and so on, you'll see that there is a constant rise in the number of vaccines which are being procured and the number of vaccines which are being administered. And therefore, I think as far as vaccination is concerned, I would say that the guidelines are worked. Again, let me reiterate that the guidelines have not worked because everybody follows the guidelines necessarily. They have worked because of the importance of the issue. And that is why we must also select on what we want to do guidelines.
Sure.
We must do guidelines on issues that are of significant importance, both in the private as well as in the public sector. I think the next thing you wanted me to speak about was sustainability, I think.
No, the
And
advocacy, the advocacy and awareness, because the guidelines are there, we want to do and implement it. But parallelly, if the demand is generated with
yeah,
the population themselves being aware and seeking out, would that be a good
so I
combination?
think that advocacy is a little misunderstood, if I may say so, because advocacy is generally perceived as something that you do which results, the end point of that advocacy is policy. And I think that is a misguided notion. I think you need advocacy at multiple levels because the groups whom you're speaking to are not homogeneous. It's a very heterogeneous group. So
Right.
let's consider, who do you need to advocate? There is obviously the classic or advocacy to policymakers, key opinion leaders, which ultimately results in some kind of a policy change. But I think advocacy also has to be done to professionals, association of professionals, and it also has to be done at a community level. We
Absolutely.
typically call advocacy at a community level IEC or awareness raising. And again, I think this is a wrong notion. I think it is advocacy. By calling it IEC, you are in a way sort of downgrading it a little bit, and you're not allowing it enough importance. I think this is advocacy at a community level, and ultimately, if you have the ability, that advocacy must also be at the individual level for the end user. And I think when all this comes together, it makes for a successful program. And again, I'll give you the example of the COVID vaccine.
Right.
It was led from bottom up. There was an absolute need, there was an absolute demand, and everybody, including industry partners, those who manufactured it, those who advocated for it, those who administered it, everybody played a singular role in this. So I think when it comes to advocacy, we are perhaps limiting ourselves when we limit advocacy to policymakers or activists or or think that advocacy should result in policy change. No, advocacy should not only result in a policy change, advocacy should also result in behavioral change. And this behavioral change should cut across the spectrum of everybody, community, professionals, ashas, midwives, and everybody should be included in this advocacy. So that's really my thought on advocacy. I think we limit ourselves when we think of advocacy as only policy.
See, we are all champions, advocates, influencers. That's how we have to see our role at large with, whomsoever we are giving this message to, so that it really translates into practice. The last piece was about collaborations with different professional organizations within the country of other specialties, as well as worldwide on the global level, to just in order to see how fast we are running the track and how well are there lessons to be learned from the experience of the others, and how you have seen it on the big canvas. Does it deter the speed? Because the collaborations are not going to be cakewalk, because everybody has a different thought process and a different way of doing things. So what has been your experience and your wise advice?
Dr. Divakar, as you are aware, I'm married to a pediatrician. So I'm very used to taking orders from pediatricians. So there is no problem working with the Indian Association of Pediatricians. But broadly speaking, I think FOGSI has always believed in the power of partnerships. I think the synergies which a partnership can bring to any activity or to any goal far outweigh the risks which partnerships can afford. I think what really needs to be done is that sometimes we rush into partnerships too fast without really looking at the areas of commonality, and then deciding that, all right, these are the areas we have in common, these are the areas that we can work with, let's work on that. A partnership doesn't have to be a marriage where you have to agree with everything as far as your wife is concerned. It can easily be a limited engagement. So if I were to be in a partnership, I would first try to identify what is our common interest, because only if there is skin in the game that partnership will be sustainable. I would then try to identify within our common interest what are our common actions and start working on that. And as the actions evolve, partnerships will become sustainable, partnerships will become long lasting. And finally, I think partnerships have to be win-win. There has to be benefit for both parties. That's the definition of partnership. If it is skewed in favor of any given partner, that partnership may start, but will never be sustainable. And I think a classic example really over here is public-private partnerships, where the terms of that public-private partnership are typically skewed in favor of the public sector, not so much towards the private sector. And I think that's probably the root cause of why public-private partnerships, typically, at least in healthcare, are not sustainable. They are very promising. For example, you say the private sector is going to fill the gaps which are there existing in the current public sector. So if it is so self-evident and obvious, why is it not sustainable? And the answer is this: that it's not created as a win-win. It's too much skewed in favor of one sector, and that's perhaps something that needs to be addressed quite urgently. I know I've already spoken.
Do you think, Dr. Tang, that we are not coming on a commonality ground as far as public and private is concerned, because private sector is always looked upon in a different way as a profit-making sector, and the trust factor between the public and the private engagement is really not so strong because of reasons such as these, and they're not doing public good. You see, they're filling in their pockets. Is that the perception? Why do you think? Because public-private partnership is the buzzword most commonly talked about, and everybody wants to do it. But as you said, it's more. There are immense opportunities to strengthen this, but it's not happening to the extent that we would have expected.
I fully agree. I mean, it's a need of the hour, honestly. The way I look at it is that the government has two roles to play in healthcare. It can either be the provider for healthcare or it can be the payer for healthcare. And when there is not enough facility for the government to provide, both in terms of capacity and in terms of human infrastructure, they should ideally be using the private sector to fill those gaps. And this doesn't happen because, as what you rightly said, there is a trust deficit. I don't think that we can pussyfoot around that issue anymore. There is a trust deficit. That trust deficit needs to be addressed, and it needs to be bridged. And I believe that what stands in the way of this trust deficit being addressed and bridged is narratives. I think that the narrative of public sector being driven purely for revenue and profit has now gained so much ground that it's become an accepted fact. I always say this when I talk about public-private partnerships, that it's not perhaps the revenue as much as what is now popularly called as the ease of business which drives. Because any private enterprise at the end of the day, any entrepreneurial enterprise, is not only about generating revenue, it's also about risk mitigation. Yes. And risk mitigation, one of the major risks that we face is regulatory risks. And if you reduce regulatory risks, for example, I run a nursing home in Mumbai and I require something to the tune of 26 or 27 licenses and permissions and things to run my nursing home. Now imagine if I were told that you have so many licenses. If you participate in this public-private partnership, we'll give you access to a single window system. Such a simple thing now with IT and tech for the government to do. And they have single window systems for so many things, including restaurants. Some states have a single window system for restaurants. Why can't you do it for healthcare? Which is so much more important, I believe, than a restaurant. Not that I like going to restaurants, but I think in terms of public health, obviously healthcare is more important. Why can't we do something as simple as this? So the problem is looking at the private sector through the lens of revenue and profit making. And I think Hrishikesh said that we cannot shy away from the fact that the private sector exists to generate revenue and make a profit. And we cannot shy away from this. But it also exists to mitigate its own risk and have an ease of doing business. And I think these both things need to be balanced. You may not pay us that much, but make it easier for us to do business. or make it easier for us to provide healthcare. And I think that will actually go a long way. So, it's a lot of nuance actually. And I think this nuance is completely lost in the current conversation.
Yeah, thank you so much, Dr. Tank, because this last point, very well taken. And also maybe, it is for us also to put forth our point in a manner that if we do this, this is what we expect. Sometimes it's obvious, but it doesn't come into everybody's mind that 27 licenses, a single window. In fact, some of the professional organizations have been battling for this, but if all professional organizations join and then it's an easy thing for the other party to do this for us. But again, we have to escalate this and certain other requests like these for the larger good, because then we have more and more private players coming into this partnership because they know that they have something in it beyond, as you said, not only the revenues, but it's so comfortable that you are privileged to get this and the other if you are in this bracket. So with that thought process of guidelines to actual action and implementation, with a win-win strategy for collaborating with all the stakeholders and with strengthening the public-private partnership in the way it should as we move along in the future, and being proud of the fact that our country has done better than what anybody would have imagined. Those are very, very positive notes on which we end the dialogue with Dr. Jaydeep Tank, and all the best to you as you move further in your professional and organizational journey. And we are all there with greater and greater enthusiasm and be inspired to do more as the years come along. Thank you so much. So
Thank
now,
you.
yeah. So now we swing to the B&B from Bengal, Basab and Bhaskar. So Basab has been sitting here for long. So Bhaskar, if you don't mind, the next question to Basab.
I think Dr. Bhaskar, I think he has to catch a flight. If he's
okay. Thank you. Thank you for guiding me on to whom to direct the question to. And Bhaskar, welcome on this panel. And the question to you would be the adult vaccination. I've often seen you in the advisory boards of the vaccines for adults, and you have very explicitly and eloquently mentioned the dangers of not actually following the recommended practices. For example, the influenza vaccine in pregnancy, which again, the capacity building about the strains and what happens if you don't give this, etc. So can you give us an insight on two of the vaccines? One is the influenza vaccine, which is beyond the routine immunizations that the gynecologists in the women's healthcare space are used to doing. How much, in your mind, after several advisory board meetings, several of the campaigns, several of the guidelines being put in place, where do you see this being implemented and the coverage of the influenza vaccine? The next important, very, very significant roadblock has been for the escalation of the use of HPV vaccine, which is before and beyond the pregnancies as well. So why these two haven't gained as much positioning as they should have? Bhaskar.
Thank you, Hema. As I will echo what Jaydeep and Hrishikesh said, Hema is a dynamite and it is a role model for us, with the kind of energy levels Hema has. Yes, Hema, I will take these two one by one. Now, the influenza vaccine in pregnancy is something which is not picked up very well. There are people who believe in it, they routinely use it. And what happened in India is that I have been associated, I've been in my practice for 20 years, I've been with FOGSI in 20 years, and I can see that the great strides we made in maternal mortality. But when the maternal mortality decreases to under 100, we need to be aware of, at the present moment, the deaths from influenza in pregnancy, the deaths from thrombosis. These are the cases that are going to now stand out. And this is the time now to move ahead of just hemorrhage, sepsis, and hypertension, and move into these causes. Anybody who's seen a woman with influenza in pregnancy, and especially the H1N1, which is now endemic in the community, and have seen them ventilated, have a prolonged morbidity, would never forget in their life to give the influenza vaccine. People argue about the cost of the influenza vaccine, but you have to look at the cost benefit. So I personally must say that I have never forgotten to give the influenza vaccine after I had a lady in advanced pregnancy with H1N1 who was one of the first patients of ECMO in Calcutta around 15 years back. Mm-hmm. And that is where I think, as gynecologists, unlike pediatricians, we are not very used to accepting new vaccines. It takes a long time for us to accept a vaccine. Yeah. The good news is that in pregnancy, the acceptance from women is great. So women will never say no to something if you can tell them that this needs to be taken for you. And that is why I think we need a lot of education, and we need to piggyback the influenza vaccine to one of the visits. Like I piggyback it to the 12-week scan. The day they come to do the 12-week scan, that is the day they get their influenza vaccine. Because if we do not do that, then we will miss it out doing that. So influenza vaccine has to be given in this day and age because it is a preventable morbidity and mortality. The HPV vaccine is, on the other hand, a more sad story. Here we've done enough programs, and we have taken this to the doctors, the community. And in spite of what is good news is among patients, the awareness has increased. There are people who come and say that, can my daughter take the HPV vaccine? Yes. But unfortunately, there's still a lot of vaccine hesitancy among doctors. And that is because of things they read on the internet or media rather than looking at what is an evidence. Although it is picking up, it is not picking up as well as it should. And I have always said this, that we've been 75 years of independence and we've not managed to have a screening program in place. But our strength has been immunization. In immunization, all of you are saying that we have been one of the world leaders in immunization, the way we eradicated polio. So for us to deal with cancer cervix, immunization is a much better idea. And even from a public sector point of view, at the present moment that we have the data that a single dose vaccine in under 15 years of age is very useful. So in the public sector, we need to sit down, talk to the government about having this as a strategy to prevent cervical cancer. The other important thing that we can do at the present moment, and many of us are doing, that in India, we can see a cancer cervix rise in the mid-50s, which means that these ladies get an HPV infection in their mid-30s. And that is why we should use pregnancy at a optimum time to talk to women about the vaccination. Absolutely. And give them, when they are lactating, give them the first dose. Then the acceptance increases. When they take the first dose before leaving the hospital, the acceptance will increase for the second and third doses. And this is how we can cover a lot of population who otherwise have escaped getting the vaccine.
There are two things around this I wanted to ask you, Bhaskar. Is it because it is gender specific that this issue about HPV vaccination has not occupied the center stage? If it was for both boys and girls, maybe the boys would have got a preference anyway, but maybe many more would have known about it. Or because of such a distinction still yet in our country, because every seminar on HPV, somebody will get up and ask, can this be given to the boys? You give the girls and the women who deserve it first. Yeah, but that question always comes, as a strong thing. And secondly, do women's attitude also matter, saying that it may not happen to me, or let me see when it happens, then I'm not the priority in my house? Have you seen such social, cultural, contextual factors around this, or are we making this up?
I think that, of course, the girls' vaccination is much more of a cost-effective strategy than male vaccination. I think these days the parents are much more inclined to giving their daughters the HPV vaccine. The problem is that we are pushing the HPV vaccine somewhere around 14, 15, and that is time. It is difficult to catch them. All the girls, they are under their parents' control at the age of 10 when they go for their second booster of tetanus. So I think the strategy should be giving them the cervical cancer vaccine at the age of 10. The moment they get into 15, 20s, And I think it is true for us also. If no adolescent is bothered about what might happen to him or her 20 years later, and for them, the life ends in the next 5 years. And so it is very difficult because they've escaped the ambit of the pediatrician, haven't still come into the ambit of the gynecologist. So that is a no man's land where it is going to be very difficult to catch them.
True.
So the vaccination strategy has to be school-based, or since we have everybody coming in to take a shot of tetanus at the age of 10 years, is to do that. I don't think that, I think India has made great strides, especially in the urban areas. I think Bengal, actually, we do not see any differentiation between how the boys are treated and how the girls are treated. So we really don't face that. But I think these days parents are much more favorable to their daughters taking the vaccine than the daughters themselves. So once they have a mind of their own, it is very difficult to convince them to take a vaccine which will prevent a cancer 20 years later.
Yeah, and given the fact that this is, the quadrivalent vaccine is licensed up to the age of 45, we have many wellness-driven programs in the corporates where many women employees, educated ones, are participating in that.
Correct.
They are like 20, 22, 25, 28, but it's also quite challenging to convince them that this is really something so very important. What has been your experience with the educated, empowered group of women? Do they think it's okay, let me see later, or what? That was the second part of the question.
I think the uptake among educated women who are working, etc., it's very good. I think the main problem that I face is with the college students, adolescents. It's a question of who will pay. They are not reluctant. They're reluctant to go and ask their parents to pay, and they are the bigger problem. I think our uptake also in the corporate sector is very good. And if we can vaccinate them by the age of 26 or 30, I think it's great. We need to take every opportunity we can to vaccinate women.
Excellent. So we've talked about two more very important vaccines, influenza vaccine and the HPV vaccine. So Bhaskar, now you can be on cloud 9 and catch your flight on time. Thank you so very much for being on this panel. Thank you. So, Basab, I will come to Chinmay last because RH isoincompatibility is a big, issue by itself, which needs a special focus. So I will tackle that right at the end. Basab, now the question to you is, have there been any changes introduced in vaccinating the pregnant women in the country, like the DTaP vaccines, for example, and of course the influenza, which he has said. Especially 2 doses of tetanus toxoid is all that the women, public or private, were aware of, and that was, happening quite on a massive coverage set. How many of our own members in our organization have shifted from this traditional concept to giving the newer vaccines as per the newer schedule? What has been your sense about that working in this? And the second question to you would be, postpartum, Bhaskar said, is an important, phase where the targets can be addressed. Are there lots of concerns of these women? What will happen to the breastfeeding? And are there so many myths and barriers which disallow you, though you have talked them through in the pregnancy? There's somebody in the family saying, no, we'll see about you afterwards. First, let's take care of the child, etc. And the third question would be on you, very much on the contraception, abortion space. So are there still misconceptions running in the minds of the peer group or the women themselves that they have taken the first HPV vaccine and they've fallen pregnant? Can they continue the pregnancy, or they will miss the second dose? So should they restart all over again? So these are a few things that need to be addressed. And post-abortion, as in post-delivery, is that also a good opportunity to drive in some of these vaccines which are so very crucial? Basab, all yours.
Thank you, Dr. Hema. It's such a pleasure being here. So just the first one, let's start with the Tdap, the one which you said about the second part of pregnancy. So now we know that from the tetanus, the government public sector has moved from TD and TD. So there are 2 TD doses which are given. So what you miss out is the pertussis, and it is definitely considered to be very important by our pediatrician colleagues. How much of Tdap is given in a private sector or at the third trimester or from 26 to 32 weeks as it is prescribed or as it is recommended? It's quite few. It's not, again, there'll be the uptake in the urban sector would be at the most, I would say 25 to 30%. But I think there's an important point here, which I think is important to reiterate. We need to really sit down and with the people who are not giving the vaccine or not offering the vaccine to pregnant women in what the issue is. It's not that always that they're not convinced that it'll work or not work or whether it'll affect the baby or not affect the baby. But I think there's also an issue of logistics, about where the cold chain, how to give it, where to have it, where to stock it. A lot of people have their own clinics where it's easy to stock. But if you don't have your own clinic, then where do you stock it? Where do you get it from? Where do you send the people to? I think a little bit of hand holding to the skeptics, I think, would be a very important point in the beginning to make sure that you have more wider utilization of the vaccine. And these are things which people don't bring up unless you ask them, because they feel hesitant that they are ignorant about this thing, about what to do or how to. They may be in their best interest. They want to vaccinate, but they just don't know in a private sector where all to send. So I think that's something which I think would demand some amount of attention and again, a little bit of research into why people are not vaccinating, people who are convinced it is better and yet are not getting the chance or not getting the thing. The other
Just
thing,
one interruption, Basab. Do you think the old-time practitioners who are still continuing to give their whole TT, how much have they shifted their focus? They know this is, the change of protocol and they ought to be giving. What is your sense of implementing the new protocol right across the country? Where have we reached?
So among the old practitioners, let's say post 50, post 60, post 70, there are a lot of people who are still practicing. Some of them come to the CME programs, which are happening on the webinars online and offline. And some of them are very much interested into the recent advances and try to adopt them into their clinical practice. There's a segment who is hesitant, who you cannot really penetrate, but there is a large amount of a segment who are embracing the changes, because the noise that we are making through these webinars, through offline symposium is quite loud, and it is creating some amount of change. It's not always measurable how much of change we are doing, but definitely it is making an impact. There's no question about it. About the postpartum part, which you had mentioned, the postpartum, I think one important point here is to get things printed on paper rather than saying it verbally. So I think whenever you have antenatal cards in each private sector also, if you can have something similar where you print that this is your third trimester, your Tdap is due, madam. This is your postpartum, you haven't had your HPV, it's due. This is dose 1. So whatever is written and whatever is printed usually carries much more significance than when it's verbally said, and you won't miss out. So it's like a checklist. Also, it's something like which you just would like to follow. So whenever you're giving her the talk about whether she wants to preserve stem cells, what type of delivery she wants, what type of analgesia she wants, then again, after that would come in the postpartum visit. You check for contraception, you check for anemia, you check for your thyroid medication, what dose you are on, you check for your GDM things, and then also you check for your vaccination. So it comes in the same go with your postpartum exercises. So that entire gamut of things should be offered as a whole. And I think that is something which we do miss out. Again, your mommy makeovers also can cover at the same time. I think it's a full package that the entire postpartum woman needs to be taken care of. And so that is something I think which we aren't doing as great as possibly we should. We again need to have a lot of more focus. It's a great opportunity postpartum, post-abortion, and we just can't miss out on these sections because these are opportunistic reasons. The same reason why we use contraception, because we want to prevent an unintended pregnancy. The same reason we want to give vaccination, because we want to prevent a preventable illness. So I think it's a very important point that you make. All of us are aware, but I think the sensitization in the medical community has to be increased. People have to hear more about it. The HPV awareness, as you said, is actually very it's lacking in the non-gynecology sector. So the non-OBGYN, non-pediatrician age group people, your neurologists, your cardiologists are hesitant to give their children. They're not very sure about it. Sometimes they ask the gynecologist, sometimes they don't ask. So unless it spreads in the medical community, it won't go much further. So I think that's a very important point. Every drop counts. In whichever way we can reach out, mass media, brand ambassadors, through medical discussions, informal discussions, and at all levels, corporate, non-corporate, everything is useful.
Excellent. The buzz around this should not only have a cascading effect within our own peer group and expanding the target population of pre-pregnancy, post-abortion, post-delivery, and non-pregnant patient, just about every touch point where we have the opportunity, we must use it to the best of the advantage. And it's not a big deal about the myths and misconceptions. If you tell them the right information and in a simple and understandable way, I really do not think the hesitancy factor or the reluctance to actually receive the vaccine, that is fairly a lesser percentage rather than we proactively doing. And of course, every single person with whichever specialty they are in touch with, if we all do not sing the same song, then we are in trouble, because it is very difficult for them to unlearn and relearn the right facts. So it is also good for us to do our own groundwork, not only within the OBGYN specialists, but specialists and frontline healthcare providers right across. So thank you so much, Basant. And you have many more years to lead this movement in the country. So we will yet again prove that India has done good on all these fronts that we spoke about. So thank you so much. Now the challenge to Chinmay, who is day in and day out in the sphere of fetal medicine, facing many such challenges even before the baby is born. So this entire concept about immunization, Chinmay, I want you to explain in simple terms, what do these vaccines do, live or attenuated? And in a similar way, it's time now not to match the horoscope, or also to match the horoscopes of the couple, but also to match the blood groups. So that is the situation with respect to RH isoimmunization. So tell us what this is all about and what we can do.
Thank you very much, madam.
And thank you for your patience. Thank you.
It's an honor to be part of this very, very eminent panel. So listening to people who make policies is all about a lot of population-based approach, whereas when we deal with individual patients, what we realize is even if it is just that one fetus who's getting affected by a particular problem, for a family, it means the end of the world. And therefore, if we can prevent the problem for that one fetus also, it is very much worth it. And while all the other vaccinations are dealing with infective processes and things which you can sometimes, cover yourself from or avoid it in some way or the other, rhesus isoimmunization, madam, even if we try and match the blood groups, is not completely avoidable, because there is a sizable number of people who are rhesus negative. Yes. When they are rhesus negative, and a woman is rhesus negative, she does not have any antigen or antibody inherently in her body. But if she is exposed to the D antigen through any kind of blood exposure, either through a blood transfusion or through the blood that comes in from the fetal cells in utero, she will develop antibodies against that antigen. So the first pregnancy generally passes without any problems, but if the woman already has antibodies and conceives a fetus who is rhesus positive, her antibodies can play havoc in the blood system of the baby, and they can cause fetal anemia, leading to fetal hydrops and eventually a loss of the fetus. Rhesus isoimmunization is one of the leading causes of preventable neonatal morbidity and mortality, and morbidity in terms of jaundice that can lead to long-term neurological deficit.
So what really happens to these little babies, and what do you see when you do their ultrasound scan, even when the child is in the womb? Can you figure this out? Can you do some special test for the mother, for the baby, and the scans which will tell you where we are going?
Absolutely, ma'am. So when a woman is rhesus negative and she's carrying a fetus who may be positive, because the father's blood group is positive, there's either a 50 to 100% chance that the baby may be positive. We know that this is an incompatible pregnancy. So in those cases, we prospectively look for signs of problems in the fetus. So as I said, the problem will be less blood or anemia in the fetus. And therefore, we look at the middle cerebral artery Doppler in the fetus, which tells us the peak systolic velocity of the middle cerebral artery is an indicator of fetal anemia. So that is a non-invasive way of screening for fetal anemia. If we don't have any idea and a woman comes to us for a scan and we see that the fetus is showing signs of hydrops or signs of fetal anemia leading to cardiovascular failure, then we suspect rhesus isoimmunization if she is rhesus negative. We check
Hydrops
for,
means it's like a balloon.
there is
Every
fluid
part of the
collected.
body is.
Yes, ma'am. There's fluid collected in various components of the fetal body, at least 3 compartments. And there are signs of cardiovascular failure, which can be detected on ultrasound. So then we check for the mother's blood group. If she is rhesus negative, we check for a test called indirect Coombs test, ICT. And this ICT, if it is positive, it tells us that the mother has antibodies, which could be the cause of the problem in the fetus. So honestly speaking, madam, checking blood group is part of every antenatal care. That should happen. It is unfortunate that we have to reiterate this fact that it should happen, because sometimes it doesn't happen. And more importantly, if somebody is rhesus negative, checking for the indirect Coombs test at the time of booking also should happen, irrespective of her parity, irrespective of her previous history, irrespective of anything.
So the warning on the board is check your blood group.
Absolutely.
If you're RH negative and you're a woman, that means potentially you will carry the pregnancy, then please check your husband's blood group. If the husband is positive, he is positive and you're negative, so the baby in your womb can be in trouble 50 to 100% of the times. If you have to identify this trouble, you'll also do some special checks to the mom. And there are several things that Chinmay said in technical terms. When she does the scanning, she figures all this out and she can figure out whether this baby is doing good or the mother has already produced some fighter cells which will fight with the cells of her own baby. And that's called ISO immunization. That, the baby is being, to use crude lay terms, is being killed by the own mother because the mother is having those cells fighting against something that her body does not accept. Why? Because these cells are positive cells which have come from the father genetically. So this is the whole scenario. So whenever you get a combination that the lady is RH negative, the husband is RH positive, some extra tests, some reference to the specialist, some helplines to actually understand, because there's a lot more to do as the pregnancy moves along. But Chinmay, now you tell.
Yes.
Do they have to necessarily go through all this, or they could have prevented this in the first place? What is it about?
That's the exact point. So this is all a created problem. It's not all, I won't call it a man-made or anything, but it is a problem which happens because of an event. It happens because of an event of the exposure of positive blood cells to a woman who's otherwise negative. So if you can prevent the formation of autoantibodies there, then you can mitigate the entire story and it actually becomes a very pleasant outcome. So all we need to do is identify the points when the mother could be exposed to the fetal cells. And if any such sensitizing event happens, then we give a prophylactic dose of antibodies there, which are known as the anti-D antibodies. And these antibodies perform a work like blocking antibodies. So they kind of block the immunological interaction between the mother and the fetus, and they do not allow the mother to produce her own antibodies, which can eventually go and damage the baby. So this is a very, very important intervention. And in the last century, the advent of the anti-D immunization actually reduced the incidence of rhesus isoimmunization from one of the leading causes of perinatal mortality and morbidity to a very, very negligible percentage in places where it has been used properly. Now, in India, we have access, we have awareness, we have everything, ma'am, but still sometimes we, miss the train and we are still seeing cases of rhesus isoimmunization.
Yeah. So there are two ways of, tackling this. One is every frontline provider, every doctor, every specialist who is in the women's healthcare space, please, the blood group needs to be checked. If it is negative, please see, rare combinations, husband is also negative, then we are free, the child will also be negative, RH negative, and then we all okay with everything. But if the father is Rh positive, then vaccines are meant for what? They are meant for prevention. An ounce of prevention is better than a pound of cure.
Yeah.
So we are going to institute the same preventive methodology, the same preventive philosophy, just like how we give vaccines to keep yourself free from the disease process. You give the anti-D to the mother in the 6th or 7th month of pregnancy itself, even in her very first pregnancy, so that there is no chance that the cells, fighter cells are formed and then it crosses to the fetus, and then the disastrous effect and the kind of unpredictable outcome, all that you can do away with. Why we give it to all the mothers? Because we don't know whether the child is carrying the father's Rh positive blood group or the mother's Rh negative. After the child is born, you can always find this out. And if the child is negative, then you don't have to anyway do anything, because the mother has not prepared any fighter cells against her own cells, and then all is good. But if the child turns out to be Rh positive, then you have to give a top-up dose to the mother. So there is a prevention even for this Rh positive negative issues. You know that there is an issue. Some couples are very frightened because they are not aware of the preventive precaution that can be taken from the very first pregnancy or abortion or whatever. As Chinmay said, the steps where the pregnancy is interfered with, even during the course of 9 months, you will need to give this like a vaccine, like a preventive precaution, to see to it that not only her first pregnancy, but all her pregnancies are safe. Yes, Chinmay, your closing statement.
So in pregnancy, there are some sensitizing events, like if she has bleeding or trauma, or you're doing an invasive procedure. Those are incidents where we definitely want to give anti-D, because we have seen that there is a sensitizing event. But even when there is no sensitizing event, every antenatal woman who's rhesus negative and not isoimmunized so far should receive a preventive anti-D injection between 28 to 34 weeks of pregnancy. At least one dose of 300 micrograms also will suffice. There are various recommendations given by various bodies where they say 2 doses antenatal. But in India, we've decided that even 1 dose should be enough. But if we don't do that, 0.2% of pregnancies will get isoimmunized under our watch, without us suspecting it.
Yeah. So in this panel on the role of vaccines in the 1,000 days, that is in pregnancy and infancy, toddler and adult vaccination there onwards, we have discussed that in pregnancy, apart from the routine vaccination schedule of tetanus, which has also changed to tetanus toxoid, tetanus diphtheria and pertussis, that is a triple vaccine which prevents the other 2 dreaded diseases, giving protection to the baby as it is born. The anti-D, which Dr. Chinmay mentioned, if she is Rh negative, the influenza vaccine. Hopefully, she would have taken the COVID vaccine before, and you have another opportunity to give the vaccine against cervical cancer, that is the HPV vaccine. So there is a lot happening in the vaccine space.
And rubella, ma'am.
Yeah, rubella also is pre-pregnancy, and now we are finding that all the children in the country, with the Indradhanush program of a massive coverage of vaccination, if many of these vaccines can come within the age of 10 years, then there will be very few left for us as specialist OBGYNs to give her before, during, or after pregnancy. So that is the vision with which we are moving. Definitely prevent illness and promote wellness is the mantra. Let's all join hands with all the stakeholders, the lay public, the professional organizations, the girls, women and families themselves, and of course the vaccine manufacturers and the government, to join hands to walk on to the pathway of prevention and wellness. With that, I once again thank all my distinguished panelists.